We now have 10-15 minutes for questions. Please express your questions as loudly as possible, and hopefully we'll get you microphones as well. Wait for the microphone. Any questions? Question one, clear, please.
There's no real mention of the young guide or reception.
Hang on a second, we'll the microphone.
So there's no real mention in the Young Practitioner's Guide or the selection criteria when to take your second series of PAs for periodontal disease?
No, you're right, and everything goes back to justification. So whereas your bite wings, they ask you to sort of think about intervals. I think with perio, I have to be wanting to get information that's going to make a difference to what I'm going to do next. So I've either got to be thinking that something's getting worse and I want to know why. Am I thinking there's an infrabony defect happened or some sort of perioendo issue? I don't have a set pattern or recall interval for periapical radiograph series for my perio cases, because you can monitor perio without taking lots of radiographs. Your 6-point pocket charts and your recession will give you a much better idea of stability than taking x-rays. You know, it takes years potentially in chronic cases for bone levels to be truly detectable. So they're not the most discerning thing for monitoring disease. It's not answering your question. I'm not going to give you a figure, but it's a case-by-case, risk-based, you know, I need to make a decision on this case, I need more information. So just justify it. Don't take screening x-rays for perio, if that makes sense. Your bite wings, in a non-periodontally compromised patient, your bite wings will hopefully have bone levels on. The day they don't, you know, you've got a perio case on your hands and then you're going to think about something else. So I know the BSP haven't produced guidelines on that because it's patient by patient. Sorry about that. Bit of a woolly answer.
Any further questions? James?
This could be difficult.
Yeah.
Thanks, Ian. Really enjoyed that very much. Just a couple of points. Firstly, about ownership of the disease. How do you deal with patients and who owns the disease?
A few things. We explain their role. So one of the things I do is I draw lots of pictures. Some of you have been on some of the courses we've done. Phil Hour talks about using the patient's sleeve, and he talks about pockets and probing, and he talks about recession, and he does all sorts of weird and wonderful things. But we explain to the patient that it's their body's reaction to the build-up on their teeth, and we're using these words all the time. So they have to clean their teeth to control their plaque on their teeth that manages their disease. We've also changed our terminology around things like periodontal maintenance, because maintenance is something you do for the patient. And it's such a silly thing, but we talk about supportive therapy, and it's a nonsense. But some patients hang on every word. So the patients fully understand it's their disease, they own it, they're the only ones who are going to get worse if they don't follow on with the treatment. We're there to help, we're going to make a big difference, but ultimately they're going to manage and control this disease. And without that, their disease is going to get worse. And we just use those words very specifically all the time.
It is a problem that pops up. You see in letters that you have not looked after. So the ownership of the disease is significant in throwing it across to the patient, isn't it?
Absolutely. I think patients think, it's the one part of dentistry, you all know this, it's the one part of dentistry where you don't turn up, have a root canal treatment and it's fixed, have a filling and it's fixed. This is a chronic disease. And I talk to patients about this. I explain it's like diabetes, it's like arthritis. Those conditions aren't fixed, they're chronic, and we talk more about periodontal management than we do periodontal treatment. And the patients have to understand that it's their thing that they need to manage with our support. But yeah, terminology and simple switching of words can make a huge difference to the patient's understanding, I think. It seems to work for me.
And then just a couple of comments which may be helpful in terms of the patient who has left a practice and is informed by a new practitioner. All of the aggression, anger, angst, it can become a very acrimonious complaint against that previous situation. So you have the GDC component as well as a claim. And when you're talking about, it's helpful to have this information in the records, etc. Couldn't agree more, because generally as a clinician, as a profession, we haven't been particularly good at recording that. And on top of the fact that you are positioning yourself to be able to defend, Yep, that sounds great. You know, we manage a mutual fund. If there's less drawings, less membership fees, all great stuff. But I would add that those of you, and you'll see it every day, who take the time to sit with the patient, explain what they have, go through it with them. A number of colleagues in the room now and in the past year must have heard patients saying to them, no one's ever taken the time to explain it to me. Bang, your goodwill is building up and up and up. So the defence, if you like, almost is a secondary to building up the goodwill, and with that goodwill there's a trust, a practice builder, a happy relationship that moves forward. So just an additional comment.
Yeah, I couldn't agree more, because it makes you look like the clinician that you are. You've diagnosed a condition that's obviously there, that the x-rays don't lie. You know, it's not, you're not selling veneers, you're not selling, you know, cosmetics, you're selling health. I find it a doddle to sell perio treatment because you're selling health, and there's no reason not to be communicating that information to the patients. I couldn't agree more. You build a very, very powerful following. These patients become incredibly loyal. From a financial point of view, they require regular maintenance. Those patients will be with you for life, and they will generate income for your practice, and we're in practice to make a living, but to treat patients the right way doing that. And perio practice can be, you know, very rewarding and equally can pay. I'm testimony to the fact that, you know, my practice pays my bills just treating perio disease alone, and they mostly find that hard to believe. But it potentially, you know, think about perio as a career.
Thanks, Ian.
Thank you. Any further questions at all?
One more at the back. Oh,
Lady at the back.
Susie.
Thank you very much. Thank you. That was really informative and useful. Thank you, especially the phraseology that you say to patients and what you see on that day really help, because there's such a blame culture and criticising one another within dentistry that, you know, it's great to try and get rid of, really, because I think ultimately we're all trying to do our best on that day. To help patients, what would you say about the prevalence of the periodontal disease? Because sometimes it can help if they don't feel like they're the only ones with that problem and the dentist has missed that problem and it's just them.
Absolutely. I've had patients say to me, you know, you make the diagnosis and they say, God, aren't I unlucky? Not really. You know, 83% of over 65-year-olds have some form of radiographic bone loss. We know that from the Adult Dental Public Health Survey. It's a hugely prevalent disease. 15% of the population have severe disease. So they're not in a minority group. You know, across the board, patients who are of an older age are going to have some levels of periodontal disease. Okay, different levels of susceptibility, different levels of disease, but they're not unique, you know, rare diseases. Okay, aggressive disease. I think with patients with aggressive disease could probably feel a little bit hard done to. And it is a horrible condition. They're clean patients, they've got no risk factors, and it does so much damage. But even then, you know, I said to you, 2.5% to 5% is the epidemiology amongst certain racial groups. So it's still a fairly prevalent condition. They're not in a you know, a tiny little group. So they're the sort of figures I would quote. If that's helpful.
Thank you.
There was one more. I think Susie had a hand up.
Susie.
Thanks very much indeed. I really enjoyed that.
Thank you.
Excellent. Just a question. You were talking about hygienists and those of us who are lucky enough to work with a hygienist in practice. And the teamwork there strikes me as being all important. How much information do you write in your prescription to a team member? Clearly they need a diagnosis in the first place, but yeah. Is that enough? Do you just say get on with it, or are you very specific about what you want them to do?
I tend to be reasonably specific, but I suppose I'm in a fairly different situation. Talking to certain hygiene groups, and I speak around the country to different groups, and talking to certain members of the hygiene community, they believe that if you've got a diagnosis with a BPE, that they can the scope of practice says they can plan the care and plan the delivery. You don't have to tell them that you want quadrant scaling and root planing or full mouth debridement. They can plan that themselves as long as they've got the diagnosis to work to. Obviously, you've got issues around prescriptions for anaesthetic, if that's appropriate. Obviously, they can get these group directives if they're in NHS practices. But I think there's an element of laziness in not just giving a little bit of guidance. I try and have a prescription that basically just lets the hygienist do almost whatever they want, because I work with hygienists who I trust. They know the job inside out. They're as good at me as non-surgical therapy, probably slightly better. And I try and give them something. So off the top of my head, my prescription says something on the lines of, patient diagnosed with chronic periodontitis, please provide a course of non-surgical therapy to include oral hygiene instruction, loss of attachment charts, and non-surgical debridement. Please send that patient back to me 3 months after you complete that round of treatment. And it's just please use LA if required, and I've put the LA prescription in. But it's a real, go on, just get on with the job that we know that you can do really well. I'm not overly prescriptive. Some people say if the diagnosis is there, ref hygienist, please see and treat is acceptable. It seems a bit lazy to me. I don't know where you guys sit on that, because that's purely my opinion. James is nodding, that's always a good thing.
Thank you, Susie. Any further questions at all? Somebody have their hand up on the left?
Who'd have thought we'd have gone to a perio lecture and had questions at the end? Normally everyone wants to get to the tea and coffee.
Thank you.
Hiya.
Hi.
We probably missed the talks yesterday. We only came for today's conference. You said to consider it as a career. Like, what did you do to get where you are today then?
Okay. Mine was a real back-to-front pathway. I spent 7 years in general practice, which I thoroughly enjoyed. Knew I wanted to be involved in teaching, so went to Liverpool University, did a session a week teaching, in fact, not even teaching, in like the A&E department, but pushed my way in. A job came up in perio. I took it, and I thought it was a step ladder onto the restorative job that I ultimately wanted, all the glory stuff, crown and bridge, and then thought, actually, this is quite good, and people aren't doing it particularly well, and it's actually quite easy when you do it properly. And then I got involved in the sort of the juicy side, the sexy perio, the surgery, the mucogingival, the regenerate. I get quite excited about that side of things. You know, regeneration. I don't need to think that a career in perio means you're going to go around scaling teeth, because you definitely don't. It's a hugely rewarding career from a diagnostic point of view. So I then got drawn into by the perio specialist within the hospital, and they gave me surgical training. I then went and did an MSc, so it was all a bit back to front. But equally, I've got there. I'm now teaching lead, practice limited to perio, and it's hugely rewarding. I think if you've got any idea that you want to focus, if you can be that driven. I mean, I was 7 years in with a mortgage and my first child. I couldn't go and do specialist training, the classic specialist training. I think if you could, I mean, what a fabulous career, because it lends itself to implants. The soft, you look through Europe and the States, and the implant world is driven by the periodontists. In the UK, we're not quite there. But the soft tissue aesthetics, that if you can do perio surgery, you can do implant surgery. And there are courses. I don't know whether it's in the Young Practitioner's Guide, but if you go to the BSP website, they have a list of the postgraduate programs around the UK. There aren't many specialist, true monospecialty programs. Kings and Guy's probably has one of the strongest. The Eastman has a great course. Newcastle have a monospecialty program. If you know you want to do it, I'd go the classic route, I really would. But if you just want to enjoy it and do it well, then part-time MSCs, there's lots of different ways. And you just know what you're doing, get a reputation within your peers that you know what you're doing, and the referrals come. We have 3 periodontists, or people taking referrals for perio in the Northwest, between Liverpool, Manchester, and Warrington, North Wales, 3. If we had 3 in Liverpool, we'd still be busy. There's a gap in the market. Truly believe that.
Thank you very much. Any further questions? Nobody?
Tea and coffee, surely.
You're going to have a long tea and coffee. Okay, can I, at that point, just thank Ian very much for an excellent speech.